It's about the state-of-the-art treatments for coronary artery disease during COVID pandemic. So, what is the commonest heart condition that requires admission in the hospital? Not only in India, but world over. It is coronary artery disease. அதாவது தமிழ்ல சொல்லணும் அப்படின்னா மாரடைப்பு நால வர ஹார்ட் ப்ராப்ளம் இதுதான் காமனஸ்ட் காஸ். ஸோ டியூரிங் த பேண்டமிக் சிச்சுவேஷன் ஹேஸ் த இன்சிடென்ட்ஸ் கம் டவுன் அப்படின்னு பார்த்தா டெஃபினட்டா கிடையாது. இட் கண்டினியூஸ் டு பி ஹை. ஸோ முதல்ல மாரடைப்புனா என்ன, கொரோனரி ஆர்டரி டிசீஸ்னா என்ன அப்படின்னு பார்த்தீங்கன்னா, இட் இஸ் அப்ஸ்ட்ரக்ஷன் இன் த பிளட் வெசல்ஸ் தட் சப்ளை தி ஹார்ட். இருதயத்துக்கு வர ரத்த குழாயில அடப்பு. So heartல how many blood vessels are there? If you look into it, there are 3 blood vessels in the heart, predominantly one in the right side for majority of the people and 2 on the left hand side. RCA on the right coronary artery and left hand side LAD and LCX and so on. So the blockages in these blood vessels is what leads to coronary artery disease or ischemic heart disease. So what can be done for such patients in a pandemic situation? All of us know that the COVID pandemic is ongoing. It has been present for the past 6 months. How long will it continue? Nobody is able to give us a concrete answer. It can continue for 6 more months, 1 year, 2 years, nobody knows. Vaccines are still in the trial, so we'll have to learn to live and cope with COVID. So what can be done for patients who are having heart problem during these times? We'll have to see. So any patient who gets admitted with coronary artery disease or heart attack has 2 options. Along with medications and lifestyle modification, they'll have to undergo the testing called coronary angiogram. That is, we directly go and visualize the blood vessels that are supplying the heart to know what is the percentage of the block, how many blood vessels are involved, and where the lesion is sitting, right at the beginning of the blood vessel or at the end of the blood vessel. Based on this, we can offer patients 2 kinds of treatment. Either the patient can undergo coronary bypass surgery or angioplasty. So which one is better? It varies from patient to patient. In this pandemic situation, which is the ideal one? That is what we are going to see now. All of us know that COVID is highly contagious. The R0 value of the virus is 3 to 4. That is, every time an infectious patient steps out of his house into the public, he can infect 3 to 4 people. That is the meaning of R0 value. And 1 ml of the infected person's sputum can contain 1 billion copies of the virus. So highly infectious and highly contagious. So what is the challenge in such scenario is patients are scared to come to the hospital and healthcare professionals are also scared. 2 reasons is they are exposed to the viral infection and the pandemic because we are the frontline warriors. Second thing is a non-COVID patient with a heart attack, when he comes into the hospital, the longer he stays in the hospital, more is a chance of him contracting the COVID virus. So what is the best treatment that we can offer for such patients who are admitted with heart attack during this pandemic time? So ideally, what is the goal is to reduce the stay of the patient in the hospital. So the lesser the time the patient spend outside his home, the lesser is his chance of contracting the virus, and lesser time in the hospital, it is both beneficial for the doctor as well as the patient. So heart patients who are at high risk or who has had a heart attack or having chest pain or breathlessness can undergo the coronary angiogram, and if found to have a problem, they must undergo either bypass surgery or angioplasty, as I've already told earlier. So the advantages of angioplasty is the stay in the hospital is going to be maximum of 3 to 4 days. And we have so much of technology. Kauvery Hospital in Nalarpet is the only cath lab in South India to have an hybrid cath lab. So they can perform procedures like CHIP. That is, the full form of CHIP is complex, high risk indicated percutaneous intervention, and also chronic total occlusion, CTO angioplasties. that is blood vessels that have been obstructed, the blockages where calcium has been deposited, even that can be opened up. I'm not undermining the role of cardiac surgeons. Definitely, there are patients who will require surgery, but we can drastically reduce the people, heart patients, from going in for surgery and give them maximum benefit with angioplasty, so as limiting the stay in the hospital. So what is the advantages of angioplasty? You see, the patients get the best and high quality of treatment in a short span of time, and it's a least invasive procedure. The entire procedure is done with a single injection, either in your thigh or in your hand, and the duration, as I already told, is going to be only 3 to 4 days, whereas when you compare with surgery, it is going to be minimum of 7 to 15 days or even more. So what should a cardiac patient do in this pandemic scenario? What are the services available? And how the heart attack or coronary artery disease can be treated effectively in a pandemic situation in a least invasive approach, that is angioplasty, without going in for surgery, is going to be our topic today. And I take immense privilege in introducing the expert panel who are available today. Two of them, I've known them for a number of years, and they are experts in their field. And we also have a person who is part of the Heart India team, who visits Chennai and does interventional procedures for chronic total occlusions all the way from US. So let me go ahead and introduce them to you. Thank you. Good evening. I think the panelists are present today. And it's a great privilege and honor for me to introduce the speakers for today. First to be talking today would be Dr. Sundar Chidambaram, MBBS, MD, DNB, FNB. Sir, I know him from 2001. Sir was my final year exam going PG, and I was CRRI in his unit. We were posted in legendary Dr. Tamilwanan's unit in Rayapeta Hospital, and I don't know whether Sir remembers or not, he was the first person to teach me how to read the ECG. So it gives me immense pleasure and great honor to chair this session where Sir is going to give a talk today. And Sir, without any further delay, I invite you to give the first address today on the topic of what are the services available, especially in this pandemic scenario for cardiac patients. And it's open for your talk, sir.
Good evening, everybody. I'm Dr. Sundar, intervention cardiologist in Kauvery Hospital. So the topic of today is acute coronary syndrome, the services we provide during this COVID times. So as we all know that we are undergoing a very tough time in this pandemic to manage the patients, to manage both the COVID patients and non-COVID patients who need an emergency care. So it's a very tough time to balance the workforce for a proper treatment of patients. So the worldwide pandemic caused by the novel severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2, has resulted in a new lethal disease termed as a COVID-19. So what are the challenges we are facing, especially in cardiac patients? So as you all know, the cardiac patients, especially the STEMI patients, the timely reperfusion is very essential. The golden hours of first 6 hours is very, very essential for the complete treatment of patients and their complete betterment. So emergency is always an emergency, even in pandemics. So the treatment of STEMI patients in this COVID times. So how we have adapted to the new challenges, especially in Kauvery Hospital, which is doing non-stop interventions even in this challenging times. So what are the challenges they are facing? It's safe regional transport and the treatment of potentially high-risk patients. So as we all know, there are a lot of problems for the patients to reach the hospital in the time, because some patients may fear and some patients may not get adequate transport to reach the hospital. And what are we going to do? And we are going to miss the golden hours in this time. So we have a very good ambulance service system, and within a click of the phone, immediate ambulance services is available that is dedicated to the cardiac patients. And we have an additional emphasis on protection and safety of all the healthcare personnels who are taking care of the patients, because the health force is vital, because they need to be very strong for the better treatment of the patients. So we have devised a very good protocol which is followed in all the Kauvery group of hospitals. So I'll put you a question. Why is the care for acute coronary syndrome and primary PCI should be organized that in a COVID times? So we can put it in this way. We have cardiac patients who can be COVID, who cannot be COVID, who are non-COVID also. So we need to treat these patients because the cardiac emergencies are emergencies. So before going into the treatment protocol, we have to organize our sources. So because of this COVID times, a lot of COVID patients, the resources we need more, because those doctors who are treating the COVID patients, they need to get adequate resources. And also we are treating the cardiac patients, we need an adequate resource for that. So here the management has a very clear idea of providing all the resources which is essential for treating COVID patients as well as the non-COVID emergencies. So we all know the pathways are disrupted in this COVID times between in the hospital, in pre-hospital. So these pathways have been cleared here in Kauvery Hospital because we have a dedicated ambulance service and we have a standardized operating protocols, how to shift the patient to the cath lab and how to shift out of the cath labs, shift the patients out of the cath labs. So we have a standard operating protocols. And also we need to take care of our staffs in extraordinary circumstances. Those health workers we are protecting with the protective gears, and we have trained our staff nurses how to don and doff the PPEs and how to be safe during procedures. So how in Kauvery Hospital, how we are protecting the patients. So when they get admitted, what are all the precautions we are doing, how we are managing the cardiac emergencies. Once the patient reaches the emergency rooms, and they will be given the protective aprons and also the mask. And once they are diagnosed with the acute coronary syndrome, with the initial stabilization in the emergency room, if the patient is not so sick, we will shift the patient to the CT screening. So where we will screen the patient's lung, and if they suspect a COVID, then all the health workers, including the doctors, will go for the PPEs. And with a full protective gear, we'll shift the patient to the cath lab and do the procedure. And after the procedure is over, we'll isolate the patient and we'll give the entire cardiac care in that isolation room. And this is the same protocol we are following in the Kauvery Hospital. And how we are protecting the health workers. Once the patient we are suspecting as COVID in a cardiac emergency, the first duty of an employer is to protect our workforce. So we have adequate PPE kits. So we have trained the staffs with the proper donning and doffing of the PPEs. And we'll adequately inquire about the well-being of the staffs, and we constantly monitor their health. And we have taught them about how to be so safe, how to avoid the spillovers, how to reduce the aerosolization from the COVID patients. These are all the adequate trainings we have given to our health force. So what are the pathways? The patient pathways need to be carefully considered in this situation. What are all the specific measures we have taken in the Kauvery Hospital? So this is the pathway for the patient to get into the cath lab. So we have drills, even mock drills we have organized, and we have organized the mock drill and how to shift the patient to the cath lab, how to avoid the spillovers, how to reduce the aerosolization. And also we have a mock drills how to shift the patient out of the cath lab and keep the staff and patients safe. And we have a green and red areas so that we'll move accordingly to the patient status of COVID. And also during post-discharge also, we have primary practices and medications. We will advise the patients about the medications, how to follow, how many months to get reviewed, and we have telephonic follow-ups also. So I'll give a short presentation of a case, which is a recent case which we did last week. How a person presented to our emergency, how we dealt with this patient. This is a 35-year-old male. He had an acute inferior wall MI. He had a severe chest pain. He was working in an office. He asked a friend to carry him to Kauvery Hospital. With a severe chest pain, he reached the emergency room. Immediately, he was shifted to the emergency bed. He was given a protective apron, mask, and we evaluated. Within first 10 minutes, we diagnosed him as a case of severe inferior wall infarction, and his BP was very low, 70 query. That means he was in cardiogenic shock. So he presented exactly at 1 p.m. in the afternoon. ER evaluation took only 10 minutes, and the patient got prepared to be moved to the cath lab. So the cath lab alert was given. Staffs are ready with PPE because the patient was so sick and cardiogenic shock, and the patient was not moved to the CT scan room for screening. Immediately he was shifted to cath lab, where we were ready with the personal protective gears adequately, and all the protocols of red lines were followed, and immediately the patient was shifted to the cath lab in a very, very protective manner. So the transportation took only 3 minutes. The intervention started exactly at 1:15, that is 1 o'clock and 15 minutes. And the procedure was over in 1 o'clock and 40 minutes. So we just give the presentation how the patient presented, and This was the left coronary section, it was normal. And this is the right coronary section. You can see 100% of the right coronary artery. Usually, the right coronary artery will come like this. This is an anomalous origin of the right coronary artery. So, this patient immediately was taken up for the PCI. So the guide was the AL 1 meter, and the wire was passed. And you can see after once the wire passed, there was the opening of the artery. So once the artery is open, we dilated. There was a it has proximal RCA, and we dilated with the balloon. And once the balloon dilatation, there was a flow established to the RCA. So we wanted to cover the lesion with the stent, and the stent was deployed. And it was post dilated adequately. And this is the final result of this patient. So you can see a very beautiful right coronary artery. The flow was established. Immediately his BP picked up, and it was a very good recovery for the patient immediately. And the swab was sent for post-op. The swab was sent for COVID, which turned out to be negative. And so this is a case example of a management of acute coronary syndrome in Kauvery Hospital. So with this talk, I just explained about what are all the precautions we are taking for the patients for our health forecast, and I just showed how we managed an acute coronary syndrome within a short span of time. And with this, I conclude my talk. Thank you very much for the opportunity.
Thank you, sir. It was indeed a very eye-opening presentation. And so, to sum it up, the key is the cardiac emergency services are available 365 days, 24/7. Pandemic or no pandemic, we are there. And this pandemic, as you know, that most of us would have been knowing that COVID is a RNA virus, and RNA viruses are not like DNA viruses. They are prone for mutation, and even though we can control it with vaccination, new mutations will occur, and COVID is going to be with us for quite some time. So any patient in the near future, we'll have to consider it, the patient, unless proven otherwise, as a COVID positive. And so the key is early diagnosis, early presentation to the emergency. And in the example that Sundar sir gave, the door to needle time was 13 minutes. I think the cath lab was ready in 10 minutes, and the shifting was done in 3 minutes, and the patient's life was saved. Young man, 35 years. So the key is early diagnosis and early shifting. And I would take this opportunity to also convey to the patients and others who are watching is, why do we do CT of the lung? Because RT-PCR, a lot of falsely negative reports are being generated, because it's a very EUA, the test itself is under EUA, emergency utilization approval. So CT lung is like considered a gold standard before we take the person for any procedure, because if there is no viral pneumonia, then we are definitely safe. But protection of both the patient and the doctor is definitely essential. And 2 days before, Abbott has released, got the FDA approval for a new test called the Binax now in the US. So it is priced at $5, and the results is going to be available in 15 minutes. So in the future, I think any patient who enters into the ER in any multi-specialty hospital, including Kauvery, I think they'll be swabbed for Binax, and the reports will be available by the time the patient is shifted to the cath lab. Thank you. And do we take the questions at the end, sir? We take the questions at the end? Yeah. So it's moving on. It's time to introduce our next speaker, Dr. Anbukarasi Maran from South Carolina. Madam is an MD, FACC and FSCSI.
in the US, and she's a part of the Heart India team, and she's a chronic total occlusion expert. And whenever she comes to India, she visits Kaveri and does some amazing interventional procedures. And she will be giving us a talk on the relevance of CTOs during COVID, because usually prior to COVID, CTO patients would wait, and we would prefer surgery, especially in this part of the world. And if the patient is not willing for surgery, then we explain them the risks of root ablation and then put them on, take them off for CTOs. And with the pandemic scenario, I think CTOs opening up chronic total occlusions carry a far more relevance. We're waiting to eagerly hear from you, madam. Over to you.
Good morning. Thank you, Dr. Goganathan, for that very generous introduction. Let me start talking about CTO PCI during the COVID pandemic. The objectives of my talk are as follows. I'm going to be talking about the importance of complete revascularizations, a little bit about the data behind CTO PCI and ischemia trials, cost-effective CTO PCI, and then we'll finish off with some case examples. We all know the syntax trial, and in this trial, we talk about the negative impact of incomplete angiographic revascularizations, especially in patients with CTOs. Okay, compared to the complete revascularization arm, the PCI group and the CABG group, incomplete revascularization arm was a surrogate marker and for worse outcomes, and was associated with significantly higher mortality from all-cause revascularizations, stent thrombosis, major cardiovascular adverse events. The reasons why CTOs where complete revascularization was not offered was the presence of a total occlusion, maybe a small insignificant vessel, not specified in some cases. The reasons PCI was unsuccessful was again presence of a total occlusion, unable to dilate the lesion, presence of an insignificant or a small vessels, etc. So overall, 60% of unsuccessful or unattempted revascularization was because of a presence of a chronic total occlusion. So let's talk about the common misconceptions about CTO PCI. There is no clinical justification. It's a stable disease. Patient has lived with it for a long time. Procedures are too complex. Success rates are low. These procedures take a long time. We don't have time for it. Results are not reproducible or teachable. CTO PCI is cost prohibitive. For all these people who say these excuses, this is what I have to say. If you want to really do something, you will find a way. And if you don't, you will find a very good excuse. And these are all just excuses. We know Grantham et al. And Safley showed that when CTO, after successful CTO PCI, the patient morbidity outcomes such as quality of life, angina scores, etc. improve. And again, Stefan Renfred et al. Also talked about in their 10-year observational studies, which included over 7,000 patients, that after successful CTO PCI, you have less angina, improved morbidity, and improved quality of life. There's also studies which talk about improvement in ejection fraction with successful revascularization. And this has been shown with MRI data also. And this is the most important study, the Explore MRI, where they talk about viability when there is less than 25% infarction or scar tissue. If you revascularize it, it has the most benefit in ejection fraction. Obviously, revascularize viable tissue, symptoms improve, and ejection fraction also improves. We also have data from the British Cardiovascular Interventional Society that patients have better outcomes as we reach complete revascularization. Again, the open CTO trial, which is a multi-center CTO PCI trial, which shows improvement in angina frequency, improvement in physical limitation, and quality of life with successful CTO PCI. Then why is ischemia trial and decision CTO kind of contradicting the other data we have? Number one, let's start with decision CTO. It was really a well-designed trial on paper, but poorly executed trial trial in reality. The study was underpowered. They had to close enrollment because they did not get patients enrolled, and there was no data on viability or symptoms. If there was a CTO, it was fixed, and the trial was a negative study. So again, for a CTO to be successful, you should have viable myocardium and you should have patient refractory symptoms. And let's move on to an ischemia trial. Ischemia trial talks about chronic stable coronary artery disease, and PCI is not effective. Again, in ischemia, they are treating stress tests. Patients need to have a moderate risk stress test, irrespective of the presence or absence of symptoms. We all know PCI helps symptoms. It improves quality of life. And there are specific instances where it can have EF and quantity of life improvement, but mostly it is quality of life. So in the absence of symptoms, doing PCI does not make sense to me. So moving on to particulars or technical aspects of crossing a CTO, it's basically 4 methods. You have a CTO right here. You can do antegrade wire escalation. You can go antegrade dissection, get into the subintimal plane of the vessel and re-enter the vessel in the true lumen. You have retrograde wire escalation, where you come through a septal or an epicardial collateral, or you dissect the vessel in the retrograde fashion and re-enter in the true lumen using your reverse cart or cart. Now, let's go through some case examples. Here we have a patient with a JCTO score of 3. This is a patient with a blunt cap. Length is greater than 20 millimeters, not centimeters, I apologize for the typo, and presence of calcification. So we decided, she had refractory symptoms, she had COPD, and we decided to do antegrade dissection re-entry method. This is a beautiful knuckle, which is crossed the entire length of the CTO, and it is in a good landing zone in my distal RCA. So now I'm aligning the Stingray balloon, which is basically a balloon with 2 exit ports. If you exit one port, you enter the true lumen. Another port, you enter into a no man's land. So I'm aligning the Stingray balloon, and this video basically shows my wire entering the true vessel distally. I'm confirming that with a retrograde injection, and now it is just IVUS guided PCI, and this is my final angiographic result. So this case is an example of antegrade dissection re-entry. Case number 2 is a 49-year-old male who presented with cardiogenic shock. He has a LAD CTO and completely dead anterior wall. And you can also see the LAD is pretty much atretic in this case. He had viability in his inferior and lateral wall. His ejection fraction was only 15%. So we decided to pursue CTO PCI of the RCA and fix his ramus/circumflex branch. The reason for fixing him was he had so many recurrent hospitalizations for angina, non-STEMI, and heart failure exacerbations. He was an unfunded patient, and basically hospital administration came to us and said, let's go ahead and bear the cost of CTO PCI because he is having too many hospitalizations, which is driving up the cost overall. So the planning, angiographic planning, he again has a blunt cap. Length is greater than 20 millimeter and presence of calcification. And my plan was dissection re-entry, go retrograde because of all the blunt cap and poor landing zone distally. And if it fails, do antegrade. So thankfully, beautiful septal collaterals from that atretic LAD before it becomes atretic. So with a microcatheter and a Sheon wire, I'm in the distal RCA. That went off very easily. Then I decided to try antegrade wire escalation. It does not fail. I'm kind of stuck in this chunk of calcium. I'm trying different aspects. It did not work. Then go back retrograde again. And with a Confianza Pro 12 failed and a Astaro 20, which is basically a peripheral wire which we use in the coronary, it was able to penetrate the calcium and get into my antegrade guide extension catheter. Once I do that, the rest is simple. I used the rotofloppy wire as my externalization wire. Used a 1.5 burr for rotational atherectomy. And this is my IVUS guided PCI, and this is my final angiographic result. Patient's EF went from 12% to 25 to 30%, and he is much better on medical therapy. Case number 3 is an African-American female who came with recurrent angina. She was ruled out for MI, but she had a large area of anterior and anteroseptal ischemia with a preserved EF. Cardiac cath was done in an outside hospital. There was a LAD CTO, minimal circumflex disease, and small RCA with moderate disease. She was tried on medical therapy, and she started failing medical therapy because she started having orthostatic symptoms with hypotension, etc. So I could not get a video of the original pictures from the outside hospital, but you can see the proximal LAD stent. Here is the stump of the LAD, and you have kind of collateral filling of the LAD distally. Again, I don't know whether this projects well, but here's the LAD stent. Thankfully, I was able to get pictures from 2009 where they did the PCI in a different hospital. So you see the stent and the LAD itself. So that gives me an idea of what the size of the LAD could be and things like that. And this is my dual angiographic pictures. RCA, as you see, is really small, some collaterals, but not a really robust filling of the LAD as I would expect in a patient who has viable anterior wall. There's a nest of collaterals in this region, again, very unclear. So at this time, I decided to just do a single angiogram from my antegrade side. And I can see that most of the collaterals is coming from circ and through this teeny tiny branch. Keep your attention focused here through this teeny tiny branch. So it's just a further depiction. This is a circ. There's an OM going here. There's a collateral going to a diagonal from the OM, and that is filling my LAD right here. Okay, and that's my target at this point. So I tried retrograde epicardial surfing. I have absolutely no clue where I am right now. So I decided, again, multiple other attempts, and I'm still not where I need to be. So I do what is called a tip injection. With this microcatheter, I inject contrast, and for a brief flash, you can see filling right here. So when you slow it down, there are collaterals right here, and here is my target area. Once you can see it, you can hopefully wire it, and this is a real-time wiring of that collateral. Yeah, obviously, I don't get it in the first try, couple of deflections, then redirect, and I'm in the LAD. So once I'm in the LAD, it's again externalization and IVUS-guided PCI, and this is my final angiographic result, and this is a repeat angiogram, and 6 weeks later, as you can see, LAD is looking beautiful. So now let's talk about budgeting your CTO card. You do need wires, but you don't need 100 different types of wire. You need a tapered tip hydrophilic wire, non-tapered tip hydrophilic wire, penetrative wire, highly penetrative wire, couple of retrograde wires, externalization wire. You don't need all of them. You need one from each family. Fielder XT, Pilot 200, Gaia, Conquest Pro. 4 wires. These 4 wires can be used for antegrade wire escalation, retrograde wire escalation, 1 Trion or a Suo wire for your retrograde septal surfing and epicardial surfing, and 1 externalization wire. You're done. Again, you need 1 company antegrade microcatheter, 1 company retrograde microcatheter, a trapper balloon, a guide extension catheter, and a snare if at all you have to snare your retrograde gear. So why should we choose PCI over CABG, especially at this time? So when you do a PCI, it's an overnight stay or a 2-day stay versus a 7 to 10 day hospitalization and 6 weeks of recovery after CABG. I had a patient with LAD and circ disease and the RCA CTO. Patient chose not to do CABG, fixed the LAD and circumflex in 1 session, 2 weeks overnight stay for that procedure. 2 weeks later, came back for a CTO PCI, another overnight stay, and 2 days patient was completely ambulatory, participating in cardiac rehab. So early ambulation is a big, big reason why PCI should be done over CABG at this time. And of course, no pump heads, whether we like it or not. It is very understated. Post-cardiopulmonary bypass cognitive impairment is a valid reason why CABG COVID should not be the first reason. And what about your obese patients? We already know patients who are obese and who get COVID have a poor outcome. To take these obese patients who have coronary artery disease and subject them to an open heart sternal wiring and all that stuff just feels like you're asking for trouble at this time. And how about patients with poor lung function? They might have intermediate lung function. Maybe they will survive a cabbage in non-COVID times, but at this time you don't want to intubate them, and then God forbid they get COVID on top of it. You're again asking for trouble. CTO PCI in experienced hands has a success rate of 85 to 9%, 95% with a 5 to 7% complication rate. In general, to conclude, CTO PCIs, for the right reasons, refractory symptoms, viable myocardium, should be offered to every patient. You can have a phenomenally successful CTO program which is running on a budget. The cost of recurrent hospitalizations for angina and heart failure eventually adds up, where you're better off just going for the CTO PCI itself. And again, it's better to be angina-free and ambulatory with PCI rather than waiting with severe coronary artery disease for the pandemic to pass over and then to plan for coronary artery bypass surgery. With this, I conclude, and I thank Heart Team India for giving me this wonderful opportunity.
Thank you, madam. That was really an exciting lecture, and I really to sum it, you made summing up easy for me, because I really like the phrase that you used. If you can do it, even though if it's difficult, find a way, either retrograde or antigrade. Do not give excuses, and like it's too complex or the success is less. Definitely, CTOs reduce the angina, improve the quality of life, and even improve the ejection fraction. And do not quote decision CTO and ischemia CTO trials, because one was poorly designed. And ischemia CTOs, as you tell, they were looking at the stress test and not considering the symptoms of the patient, because most of the patients became symptomatically better after doing the CTO. Excellent case presentations. Again, I really like the 49-year-old with an EF of 12%, and after the CTO, his EF improved to 30%. And the case study, it was straight out of like a sci-fi movie, wherein you said that you were clueless where you were, and you used that tip injection to find out where you were, and you typically quoted that once you can see it, hope you can wire it. So hope is a good thing, probably the best of all things. One of my favorite quotes, again, both for the doctor and for the patients. So in a nutshell, obese patients and during the pandemic period who have refractory symptoms and who have a viable myocardium, definitely CTOs are the way to go. And they are not difficult, they are not too complex. The success rate is as high as 85 to 95%, and in the hands of an expert. And again, to put it in a nutshell, it can be done. Do not give excuses. Find a way. Thank you. So
one thing I want to say, Dr. Gugan, the pandemic pass இருக்குல்ல, pandemic போன அப்புறம் தான் நான் டாக்டர் கிட்ட போவேங்கிறதுலாம் வேலைக்காகாது. இது எப்படின்னா, தமிழ்ல ஒரு சேயிங் இருக்குல்ல, அலை எப்போ ஓய்றது, எப்போ பீச்சுக்கு போறது மாதிரி. ஓகே, இது அலை ஓயுமா ஓயாதான்னு தெரியாது. ஸோ ப்ராப்ளம் இருந்துச்சுன்னா டெஃபினட்டா போய் ட்ரீட்மெண்ட் சீக் பண்ணணும். ப்ராப்ளமோட வாடுறது இன்னும் கஷ்டம். இப்போ இந்த கோவிட் டைம்ஸ்ல யூ வாண்ட் ஹேவ் எல்லாம் எக்ஸசைஸ் பண்ணணும். எக்ஸசைஸ் பண்ணா உங்க கோவிட் வந்தாலும் அவுட்கம்ஸ் பெட்டரா இருக்கும். நெஞ்சு வலிக்குதுன்னு எக்ஸசைஸ் பண்ணாம இருந்து அதுக்கப்புறம் கோவிட் வந்து மல்டிபிள் ஆர்கன் சிஸ்டம்ஸோட கோவிட் வந்தா அவுட்கம்ஸ் இன்னும் மோசம். அதனால பிரச்சனைன்னு இருந்துச்சுன்னா, நெஞ்சு வலின்னு இருந்துச்சுன்னா, தயவு செய்து போய் ட்ரீட்மெண்ட் சீக் பண்ணுங்க. That's what I would like to convey.
Excellent. Thank you. Thank you. Again, do we take the questions at the end? After Madam's questions at the end? Yes. Yeah. Okay. So the next topic is going to be Dr. A.B. Gopalamurugan. He is going to talk on multivessel angioplasties during COVID, complex multivessel angioplasties during COVID. And I'm not going to talk about his credentials or give a list of his degrees. I'm just going to give two examples. I think 2015 from UK, he came to Chennai, or 14. I'm not quite sure, but one of the first cases I sent to sir was a 82-year-old severe aortic aneurysm. And I think sir remembers that case.
Yeah.
On the cath lab table, the aneurysm ruptured. And on top of that, in spite of that, he was stented, and 2 weeks back he came for review to me. He's 87 now and doing pretty fine. And we really know, even on an operating table for a cardiothoracic surgeon, we know how tough is a ruptured aneurysm. But he's really enjoying the extra lease of his life. And today morning in my OP, I saw another female, 55-year-old morbidly obese female. 2018 CABG was done in a hospital in Chennai. Lima to LAD, SVG to OM1, and PDA were given. Intractable angina within 6 months of CABG. And when she came to us, we did an angio, and we found that the SVG to OM was occluded, and the PDA to SVG to PDA was also occluded. So it was too complex. Many were suggesting ECP. She was refractory to all the anti-anginal. Still, she was having grade 4 angina. It was too complex, and nothing was. She was basically suffering. So I sent her to you, and today morning she came for review after 6 months. She was so happy, hale and healthy, totally free of angina. You had put a complex multivessel PCA. You had put one stent in OM1, and CTO was totally opened up. RCA was totally opened up, the CTO. So this is the kind of service that you have been doing, transforming patients' life in the most least invasive form. So I welcome you to give the talk today.
Thank you. நீங்க அவ்வளோ நேரம் பேசிட்டு இருக்கும்போது எனக்கு ஒரு பயம், எங்க பேஷண்ட் நல்லா இருக்காங்களோ இல்லையோன்னு. பட் ஐம் கிளாட் ஷீ இஸ் டூயிங் வெல்.
Good morning.
Thank you, Govinathan. ரொம்ப நன்றி. Good evening, everyone. My task is to talk on multi-vessel and left main angioplasty during COVID. That was a fantastic talk by Dr. Anbukarasi before me, and I hope I can live up to that. So, what are the options for left main or multi-vessel disease? Currently, it's coronary artery bypass grafting. I have put Curie angioplasty, and the idea of this presentation is to go through the various options of angioplasty, and of course medical management for patients who cannot be treated by either methods, or perhaps none of the methods will give them any better quality of life. Then it's reasonable to consider medical management or perhaps palliation for that matter. There are some traditional patient statements that I hear over the years, and நிறைய பேர் have this misconceptions which I would like to point out. Patients often say there is permanent cure with bypass operation. Now, I'd like to point out that this is not accurate, because there is no cure. They often also say 3 blocks, 4 blocks, therefore angioplasty panna mudiyadhu. I think there is a misconception. This has been propagated over the years, and that's no longer true. Calcium or highly risky, adanala angioplasty panna mudiyadhu. Again, that's a misconception also. And minimally invasive bypass operation is better than CABG. What they don't understand is many patients are misinformed that it is indeed a form of bypass operation. It is only the size of the incision is slightly smaller. And of course, they had this misconception too, that bypass is permanent and angioplasty is temporary. I don't know where this comes from, but that's absolutely not scientific, and it's not true either. And that's something I'd like to convince you through this presentation. Let's talk about some basic differences from a patient perspective. So patients vandanga, they ask me, what is the difference between bypass operation and multi-vessel PCI? Of course, I'm not against bypass. Bypass is a fantastic treatment for many, many patients, time tested for decades. But what I'm trying to say is that's not the only option anymore. So if you look at bypass and multi-vessel PCI, they have to be on lifelong medications. Because there is no cure. And again, I stress this, the definition of cure is you get a normal heart. They will never get normal heart because they have coronary artery disease. They're going to have artificial treatments, either the செயற்கை முறையில blood vessel supply கூட்டுறோம். So be it bypass operation or angioplasty, they are artificial means to restore blood supply, and therefore all artificial means comes with a shelf life. So there is no cure. I think that the whole term cure cannot be used in the treatment of established coronary artery disease. That's a misconception I would like to point out. The whole idea of grafts are permanent, I think that is a misconception too. We all know, and the evidence suggests, vein grafts, which is the commonest grafts used in addition to a single arterial graft used in the form of Lima, the vein grafts occlude up to 10 to 20% at 1 year. This is a fact that many don't know, and this has to be borne in mind when considering bypass operation or multi-vessel PCI. If you look at PCI, the PCI redo rate in unselected patients at 1 year is about 10 to 12%. Return to normal quality of life is prolonged with CABG, and this has to be borne in mind, especially in the elderly. And return to normal quality of life is soon with angioplasty. Therefore, the social history and taking a holistic approach on the patient's history is very important to decide which one suits the patient best. And of course, longer time spent in hospital risks COVID, which is the case with coronary artery bypass operation. But on the other hand, multi-vessel PCI comes with a shorter time spent in hospital, and therefore risk of COVID infection from hospital is going to be minimized. So these are the myths that I would like to address, and these are no longer true. 2-vessel or 3-vessel disease equals CABG is a myth, and left main disease equals CABG is a myth too. And patients too sick, CABG, again, that's a myth. And patient in shock, CABG, in pulmonary edema, they have to go for bypass. No, it's not the case. And acute MI, and this is the worst part, that many actually think, some patients, the ill-informed, think an acute heart attack, you're best off having a coronary artery bypass operation. That is absolutely not true, and primary angioplasty is the gold standard and proven extensively, because that's the quickest way the target vessel can be opened up, restoring normal blood flow. And CABG is permanent, PCI is temporary. I think it's an absolute non-scientific point, which I've already mentioned. Let me try and convince you that these are all myths with a few case examples that will make sense. I'm not going to go into the technicality of the angioplasty, because that is not the remit of the talk. It's mainly to give a few examples as to what are the disease cohorts that we're treating here in Chennai, what are the outcomes, and perhaps I'd like to convince you with some long-term outcomes and some patient testimonials too. So I'll show you a case one. This was a case we did in 2017. This is way before COVID. So you can see here, and I hope everybody's convinced that this patient has a long segment of tubular left main stenosis and a significant proximal LAD disease with excellent distal targets. So this patient was indeed a coronary artery bypass grafting patient, but this patient, for social reasons, did not want coronary artery bypass grafting and was referred to us. So we did an IVUS guided angioplasty to the left main stem. This is an intravascular ultrasound where we use ultrasound to look inside the vessel to decide what is the treatment that is apt for this patient. And based on IVUS, I won't go into the techniques, I'll just show you the outcomes. This is the outcome that we achieved. I hope you can appreciate, I hope you remember the pre-procedural angiogram. This is the post-procedural angiogram, and this was back in 2017, which I performed in a different hospital. Now, this was 3 years after. In fact, I did this patient surveillance 2 days ago. He came to my office. I did an echocardiogram. He's asymptomatic, and this is his LV, and the LV is absolutely normal. And this is his angiogram. This was in 2020. So you can imagine the outcomes that was achieved with intravascular imaging guided angioplasty remains the same even 3 years down the line. So on the left is on the left is the outcome in 2017, on the right is the outcome in 2020, and on the top is the baseline before the angioplasty. So it goes to prove the outcome over a 3-year period, which is fantastic for left main unprotected angioplasty, which is image guided. This is case number 2. You can see here this patient has a critical distal left main disease and a large circumflex disease, again significant calcified LAD disease, a typical patient for coronary artery bypass grafting with excellent targets. But this patient was old, he was 75, so we decided to do a left main multivessel angioplasty. Again, I won't go into the techniques, but you can see here on the top and the left is the pre-procedural angiograms, and on the right is a post-procedural angiogram showing a fantastic angiographic result, and this patient continues to do well 2 years down the line. This is case number 3. I apologize, it's mentioned as case 2. This is another case. You can see here significant LAD disease. This patient was in cardiogenic shock. This was a patient who was in pulmonary edema, and we decided to take this patient up for angioplasty. This was IABP and pacing wire assisted. And you can see on the top, left and right are the pre-procedural angiograms, and on the bottom, left and right are the post-procedural angiograms showing a marked and a satisfactory angiographic result from left main and LAD and circumflex angioplasty. This is another case which I'd like to show. You can see here, this is a patient we transferred from a different district. This patient again was in pulmonary edema, was an extremis, and was declared for coronary artery bypass grafting. He was 45. This patient had impaired LV, and he did not want coronary artery bypass grafting for whatever reasons, so he was transferred from another place, and we did his procedure with IABP and ECMO support. I won't go into the procedure, but you can see the pre-procedural angiograms on the top and the post-procedural angiogram at the bottom, and this was done 2.5 years ago, and the patient continues to do very, very well. Another case, interestingly, this patient was a professor of anatomy, and he had a critical left main narrowing involving the LAD and the circumflex. I hope you can appreciate on the top the significant left main disease. So he underwent a left main angioplasty, and I won't go to the technique again, but you can see here the top 2 panels are the pre-treatment angiograms, and the bottom 2 panels are the post-treatment angiograms, and he continues to do well. Again, this is nearly 2.5 years since we did this angioplasty. So what is key to acute and long-term success in such angioplasty? So why aren't many left mains and multivessels performed? Is there a recipe for long-term success? And the recipe is essentially attention to detail, and the gold standard techniques and protocols have to be adopted. And adopting these have consistently shown on studies that they give similar outcomes, or at least near similar outcomes, to coronary bypass grafting. Image guidance, by far, this is one of the best techniques that has evolved over the years, whereby all angioplasties are guided with intravascular imaging, whereby we look inside the vessel. And there are two modalities. One is intravascular ultrasound or optical coherence tomography, abbreviated as OCT, but both do the same, essentially looking inside the vessel, because often looking at angiograms, which are essentially two-dimensional shadows, can be deceiving, and outcomes can be affected if intravascular information is not obtained. Patient education and information, of course. Intravascular ultrasound, just a small slide on what it is. This is ultrasound from inside the vessel. On the left is a normal intravascular ultrasound that shows the various layers. And this is an example on the middle screen. You can see here how this angiogram appears as though it's normal. But if you do an intravascular ultrasound, you see significant layer of disease eccentrically, because the lumen is round. Of course, the angiogram will give a nice rounded shadow, but that doesn't mean that it's normal. A similar example, you can see here on the bottom, the angiogram looks perfectly fine, the circumflex, but there is a dissection there, which you just can't see on angiography because it's a two-dimensional shadow, but here we're actually sitting inside the vessel and seeing, and therefore it helps outcomes of angioplasty. This is probably the most important use of image-guided angioplasty, because you can actually see the stent after the angioplasty. Most stents, almost all stents nowadays, are drug-eluting stents, which means they elute drugs on the inner surface of the wall of the vessel to prevent re-narrowing. They will only elute if your stent is in contact with the vessel wall. And there's no way on angiography one can say whether the stent is in contact with the vessel wall. And the only way you can say that is by looking from inside, sitting inside the vessel. And that's what an ultrasound does, whereby you can make sure the stent is well opposed to the stent wall, to the vessel wall, and thereby you're going to get effective drug elution. And that's how you're going to prevent re-narrowing. Well, is there any evidence for that? The fact is there are plenty of evidences over the years. This is a small study. I won't go into this. This is back in 2003, showing that with prospective data collection, IVUS-guided PCI provided superior outcomes, and it was cost-effective too. And the reason it is cost-effective is because patients don't get re-intervention. This is another study from Journal of Thoracic Disease. And I'll tell you another reason why IVUS should be used. It also tells us sometimes that we should not be doing an angioplasty when we would be doing it had we not used an intravascular imaging modality. So this is an example, case 5. On the left-hand screen, you can see here on the top, there's a significant right coronary disease. On the bottom, we have fixed it, straightforward angioplasty. But the patient also had moderate disease of the LAD. You can see here the angiogram of the LAD showing a moderate LAD disease. So we did an intravascular ultrasound. You can see here the various sections of ultrasound demonstrating that it was not disease, it was just a negatively remodeled vessel, which is an abnormal vessel shrinkage, but not atheromatous deposition. Therefore, this vessel doesn't need any treatment at all. So it also helps us when not to treat. So this is another imaging modality, which is optical coherence tomography, which gives high resolution images. And IVUS and OCT, they have both plus and minuses to using them. But this is roughly the kind of three-dimensional image we get after stenting. So this is a tunnel view where we're actually traversing like a roller coaster inside the vessel. This is a stented vessel. We can actually see the stents. We can look at all the branches. We can be absolutely sure there is no intraluminal pathology after stenting. We can make sure the branches are open. So this is the kind of view nowadays we get, and therefore it makes sense not to rely on two-dimensional shadows, which are angiographies, and to go with three-dimensional intravascular imaging modalities to prove efficacy of an angioplasty. This is another case I'd like to show. This is a patient who had significant left main and multivessel disease. You can see here he also had significant LAD and circumflex disease. And he also had right coronary artery disease. I hope you can appreciate the disease in the right coronary artery. There is a mid-vessel kinking and narrowing, and he underwent rotablation to the LAD. And we fixed the right coronary artery. This is the pre and post, you can see here. And the LAD, this is the pre, you can see there, typical CABG bypass patient. But we performed an angioplasty whereby it achieved a pleasing result both for the circumflex, left main, and LAD. This was intra-aortic balloon pump assisted. The patient spent 2 days. Now he's back to normal work. This was done during COVID, and I think we're going to have this patient talking very shortly about his experience, and I hope this will convince the viewers. This is just to show the same case. This was the intravascular ultrasound before the procedure on the left-hand side. That's all calcium that you see from 9 o'clock to 3 o'clock. That's why we had to use a drill, which is called rotablation. And on the right-hand side, you can see after the stent, the vessel is widely open, achieving a very good luminal area. This is the last case I'd like to show. You can see here significant disease. I hope I can convince everyone that this patient has severe diffuse disease of left main, circumflex, intermediate, LAD, but beautiful targets for coronary artery bypass grafting. This patient again was 75. He was old, so I offered him coronary angioplasty to all these vessels. And this is his angiogram, again, just to show you a few more views. And we got along with stenting all the way from the ostium of the left main, reconstructed the entire coronary tree. And this is his pre, and that's his post. You can see here a very pleasing result, and this patient is doing very well now. And this is again the pre and post. So this is a meta-analysis from over 18 lakh patients in the United States. These are real life patients from 2009 to 2017, whereby these patients were compared on outcomes between IVUS guided angioplasty and non-IVUS guided angioplasty, and it proved that image-guided angioplasty using intravascular ultrasound achieved better outcomes, less MIs, less revascularizations, and superior angiographic results. When do I use imaging? Well, virtually it's 100%. In fact, here I don't do any angioplasty without IVUS at all. So that gives me more confidence, and to be able to say at the end of the procedure that there's nothing better I could do. In fact, it allows us to shift the patient to a stable patient to the ward, because there's no reason for CCU, because the risk of stent thrombosis, inflow, outflow pathologies causing acute stent problems are all negated through direct vision at the end of a stable multivessel or left main angioplasty. So multivessel and left main PCI technique, how do we do it in 2020? What routinely happens here? All lesions are dealt with at the same time in non-acute MI. This is a non-MI cohort I'm talking about. Of course, many patients have poor LV, and we have a low threshold to use blood pressure support mechanisms like ECMO or IABP or impeller. For acute MI, our door to balloon times is about 20 minutes here. 100% is image guided. There's no angioplasty here without image guidance. There's no concern of a suboptimal PCI because they are guided with image. And therefore, if there's any concerns, it's fixed right then and there. In fact, before we start the PCI, image guidance is already set up because it's 100% done for all cases. And all stents, balloons, and bursts are all based on IVUS. So to conclude, I can see Guganathan giving a sigh. Abba, mudishtanda andra mari. almost done. So to conclude, most coronary anatomies can be treated safely with angioplasty. The elderly with multivessel left main disease probably benefit most because bypass operation, one might argue there is a mortality benefit, but somebody the age of 75, 70 வயசுக்கு அப்புறம் வயசானவங்க யாரா இருந்தாலும் it's not the longevity of life, it's the quality of life. வாழ்க்கை மேன்மை தான வைத்தியம். அப்படிங்கும்போது the quickest treatment and the least invasive option which achieves the quickest return to normal quality of life can only be the best for the patient. So I don't believe that in the elderly CABG is necessarily the best option, although it could be in some cases. Multivessel PCI or left main PCI with image guidance is the gold standard and achieves better long-term outcomes than angioplasty without image guidance. And CABG is not the only option, as I said, for left main and multivessel, although it is one of the best options for many patients. Most importantly, stay healthy. முடிஞ்ச அளவுக்கு ஹாஸ்பிட்டலுக்குள்ள வராதீங்க. அப்படி வந்தீங்கன்னா you need to get out very quickly. Especially during this COVID times. Therefore, the quickest treatment is the best option for the patient. Thank you.
Thank you, sir, for the excellent talk and the 7 case presentations. Really interesting and take-home messages to put in the nutshell. Like ending was very crisp. Like try and avoid coming to the hospital, but don't suppress the symptoms. If you're symptomatic, don't sit at home convincing yourself it is a muscular pain or it is gastritis, buying loads of Gelusil and drinking it. Please come to the hospital. If you come to the hospital, you are in the hands of experts who will do the best treatment. Please stay in the hospital and ensure that you're back to your house at the earliest. And bypass is permanent is a myth because a lot of patients redo bypass is done, and in inoperable patients also, angioplasties and stenting is done. In fact, I was taken aback by this thing that the statistics that you gave, that the venous graft occlusion is much more in the years to come than PCI occlusion. The venous graft tend to occlude more, and either it be triple vessel disease or with or without LMCA, if the patient is very sick or in shock, ideally, the patient requires angioplasty rather than CABG. It can be done even when the EF is very poor with the help of ECMO or IABP or Impella, as rightly pointed out by Sir. And acute MI, till now, the gold standard is primary angioplasty. There's no two ways about it. And in Kauvery Hospital, like Dr. Sundar pointed out in the very first the 35-year-old man was door to needle time was 13 minutes. And even in a complex unstable patient, the PCI, as Dr. Gopal Murugan pointed out, the door to needle time is as low as just 20 minutes. And the discharge from the hospital is as soon as like 3 to 4 days. And the entire procedure gets over within maximum of 2 hours, and all the vessels are addressed. And another most important takeaway point that Sir told today was always use an IVUS and intravascular ultrasound. What you get from it, it tells you, even though the blood vessel can look normal, it gives you the 3-dimensional view. So it helps you to decide whether the patient requires a stenting or not. Even after stenting, always do an IVUS to make sure that the deployment is proper, that the stent is impinging on the vessel walls completely. And it also tells you when not to do. That is more important, because even 2 or 3 of my cases which I sent to Sir, it was a myocardial bridging, which looked like a stenosis, and you did an IVUS and you did told that the patient don't request stenting. So these are the takeaway points from Sir's this thing. Excellent presentation, Sir, as always. Thank you. So do we go in for the patient video now? The case 6 patient. Going to talk about it right now.
ஹலோ, என் பேர் ஜி ஸ்ரீனிவாசன். எனக்கு ஒரு மாதம் முன்னாடி நெஞ்சில் ஒரு சின்ன வலி ஒன்று இருந்தது. ஸோ அந்த வலினால் மறுநாள் கொஞ்சம் அன்கம்ஃபர்டபுளாக ஃபீல் பண்ணினேன். எங்கள் டாக்டருக்கு ஃபோன் பண்ணி கேட்டபோது அவர் வந்து போய் ஒரு இசிஜி ஒன்று எடுத்து பார்த்துடுங்க அப்படின்னாரு. அதனால் நான் வந்து பக்கத்தில் இருக்கிற ஒரு ஹாஸ்பிட்டலில் போய் இசிஜி எடுத்தேன். ஸோ இங்கே பக்கத்தில் இருக்கிற ஹாஸ்பிட்டலில் ஒரு கார்டியாலஜிஸ்ட்டை கான்டாக்ட் பண்ணி அவரை அப்பாயின்மெண்ட் ஃபிக்ஸ் பண்ணிவிட்டு அவரை போய் பார்த்தோம். அவரும் செக் பண்ணி பார்த்துட்டு நம்ம வேணால் ஒரு ஆன்ஜியோ பண்ணி பார்த்துடலாம், ஆன்ஜியோ பண்ணினா நமக்கு என்ன பிரச்சனைன்னு தெரிய வரும் அப்படின்னு சொன்னார். ஆன்ஜியோ பண்ணிவிட்டு அது ரிசல்ட் வந்து பார்த்தபோது தான் எனக்கு வந்து மேஜர் ஆர்டரிஸில் 4 பிளாக்ஸ் இருக்குது அப்படிங்கிற மாதிரி தெரிய வந்தது. தெரிய வந்த உடனே அவங்க வந்து ரெமெடியாக என்ன பண்ணலான்னு கேட்டபோது பைபாஸ் சர்ஜரி பண்ணிக்கலாம் அப்படிங்கிற மாதிரி சொன்னாங்க. இந்த பர்டிகுலர் டயத்தில் கோவிட் வேறு இருக்குது. ஐஎம் அபவ் 60, என்னோட ஏஜ் 66க்கு மேலே ஆகிடுச்சு. எனக்கு அதர் எயில்மெண்ட்ஸ் லைக் டயபெட்டிஸ், பிபி எல்லாம் இருக்குது. அப்படிங்கிறதுனால இப்போ பண்ணிக்கிறது அட்வைசபிளாக இல்லையா, ஆர் வேறு ஏதாவது ஆல்டர்னேட்டிவ் இருக்கா அப்படின்லாம் தெரிஞ்சுக்கலான்னு கொஞ்சம் ஃப்ரெண்ட்ஸ் எல்லாம் கான்டாக்ட் பண்ணி விஷயத்தெல்லாம் கேள்விப்பட்ட போது அவங்க வந்து டாக்டர் சிவகடாட்சம் போய் பாருங்கள், he will give you a good advice அப்படின்னு சொன்னாங்க. ஸோ நான் வந்து டாக்டர் சிவகடாட்சம் போய் பார்த்தோம். அவர் அப்போ சொன்னார், உங்கள் கேஸில் உங்களுக்கு சர்ஜரி தேவைப்படாது, நம்ம இதை வந்து ஆஞ்சியோபிளாஸ்டி மூலமாகவே ஒரு மாடர்ன் டெக்னாலஜி யூஸ் பண்ணி ரோட்டோபிளாஸ்ட்னு ஒரு டெக்னாலஜி இருக்குது, அலாங் வித் கேமரா யூஸ் பண்ணி நம்ம வந்து இதை ஸ்டென்ட் வச்சு கூட சரி பண்ணிடலாம். இது வந்து செய்கிறதுக்கு டாக்டர் கோபால் முருகன் காவேரி ஹாஸ்பிட்டலில் ஒரு ஸ்பெஷலிஸ்ட் இருக்கார், நான் இப்போ அப்பாயின்மெண்ட் ஃபிக்ஸ் பண்ணி தரேன், நீங்கள் உடனே போய் பாருங்கள் அப்படின்னு சொன்னார். ஸோ அன்றைக்கி உடனே we went and met Dr. Gopal Murugan to see him to get advice. அவர் உள்ளே போய் பார்த்த முதல்லையே the first impression I had was radiance of confidence that I got. ஏன்னா அவர் வந்து முதல்ல என்ன அப்ரோச் பண்ணி என்னை கேள்வி கேட்ட விதம், அவர் என்ன பிரச்சனைன்னு கேட்டுட்டு அதை தீர எங்கிட்ட என்னை பேச விட்டு, அப்புறம் என்னுடைய அந்த சிடியை வாங்கி போட்டு பார்த்துட்டு நல்லா ஸ்டடி பண்ணிவிட்டு, then he told me whatever your problem there are 2 solutions, but I would suggest you to go for this stent procedure. இது வந்து ரோட்டோபிளாஸ்ட்னு ஒரு டெக்னாலஜி இருக்குது, அதை வச்சு நாங்கள் பண்ணுவோம் அப்படின்னு சொல்லிட்டு ஒரு ஒன்றுமே மெடிக்கல் ஃபீல்டை பற்றி தெரியாத ஒரு ஆளுக்கு புரியும்படியாக ஏந்து வந்து ஒரு போர்டில் க்ளீனாக படம் போட்டு காமிச்சு எதை என்ன பண்ண போகிறோம் அப்படிங்கிறதெல்லாம் ரொம்ப க்ளீனாக எக்ஸ்பிளைன் பண்ணார். இந்த ஆர்டரியில் இந்த இடத்துல பிளாக் இருக்குது, இந்த டோட்டல் இல் டேக் அபவுட் 4 hours பக்கம் ஆகலாம், ஒரு 3லேருந்து 4 ஸ்டென்ட் வைப்போம் அப்படிங்கிற மாதிரி எனக்கு ஒரு ஐடியா கொடுத்தாரு. நான் அவர்கிட்ட இப்போ கேட்டேன், இல்லை இப்போ வேறு இடத்துல சிஏபிஜி பண்ணலாங்கிற மாதிரி சொல்கிறாங்களே அப்படின்னு நான் கேட்டேன். அப்போ அவர் சொன்னார், சிஏபிஜி பண்ணினோம்னா இது இருக்குது, பிறன முதல்ல ஆப்ரேஷனில் இருக்கிற ரிஸ்க் இருக்குது, அது தவிர கன்வாலசன்ஸ் பீரியட் கொஞ்சம் அதிகமாக இருக்கும். இதில் வந்து இது லெஸ் இன்வேசிவ் ப்ரொசீஜர், இந்த லெஸ் இன்வேசிவ் ப்ரொசீஜர்னால யூ கேன் கெட் பேக் டு ரொட்டீன் ஃபாஸ்டர் அண்ட் உங்களுக்கு அந்த ஆப்ரேஷன் பண்ணுறதுனால வரக்கூடிய ரிஸ்க்கும் வில் பி வெரி வெரி மினிமல். அதனால் இது பண்ணிக்கலாம், நீங்கள் both are going to yield the same kind of results for you அப்படின்னு சொன்னார். your quality of life will be really better. நீங்கள் வந்து you'll be able to get back to your routine. One of the doctors which I have seen where அவங்க வந்து இன்டர்நெட் போய் பார்த்து படித்து தெரிஞ்சுட்டு வாங்கன்னு சொன்ன ஒரு டாக்டரை நான் பார்த்தேன். அவர்கிட்ட நீங்கள் எங்கிட்ட தான் வரணுங்கிறது கூட இல்லை, நீங்கள் நல்ல கரெக்டான சொல்யூஷன் எடுத்துகிட்டு எப்போ உங்களுக்கு தோணுமோ அப்போ வாங்க, பட் டூ இட் வித்தின் 15-20 டேஸுக்குள்ளே அப்படின்னு சொன்னார். அப்போ நான் அவர்கிட்ட கேட்டேன், இப்போ லாக்டவுன் இருக்குது, கொரோனா இருக்குது, இந்த பிரச்சனைகளாக இருக்குன்னா நீங்கள் லாக்டவுன் பற்றியெல்லாம் கவலைப்பட வேண்டாம், லாக்டவுனில் எல்லா இன்ஃப்ராஸ்ட்ரக்சரும் ரெடியாக இருக்கும்போது தான் நாங்கள் ப்ரொசீஜர் பண்ணுவோம். ஈவன் இஃப் 1% or 2% deficiency is going to be there in infrastructure, we will not do the treatment அப்படின்னு ஒரு அஷூரன்ஸ் கொடுத்தாரு எனக்கு. ஸோ பேஸ்ட் ஆன் தட் me to get admitted. ஸோ 23rd போய் அட்மிட் ஆனோம். 24th அன்றைக்கி ஏர்லி மார்னிங் his team was a very good team. டாக்டர் கார்த்திக் வந்து என்னை பார்த்தாரு. அப்புறம் அந்த டீம் பீப்புளையும் நான் அங்கே மீட் பண்ணேன். அவங்களுடைய அந்த தியேட்டருக்கு கூட்டிகிட்டு போனாங்க. பேக்ரவுண்டில் அந்த மியூசிக்கெல்லாம் போட்டு விட்டாங்க. they made me feel very comfortable. அப்புறம் டாக்டர் கோபால் முருகன் வந்தார். வந்துட்டு he was telling me what he is going to do and he told me நான் இந்த இடத்துல என்னென்ன பண்ணுவேங்கிறத எக்ஸ்பிளைன் பண்ணார். அப்புறம் பண்ணும்போது எங்கிட்ட சொன்னார், இந்த மாதிரி பண்ண போகிறேன் சார், இப்போ உங்களுக்கு ஒரு இன்ஜெக்ஷன் கொடுக்க போகிறேன், நீங்கள் கொஞ்சம் ஒரு செடேட்டிவாக இருக்கும், நீங்கள் இட்ஸ் லோக்கல் அனஸ்தீசியா ஒன்லி அப்படின்னு சொன்னார். கொடுத்தாங்க. ஐ வாஸ் ஏபிள் டு ஃபீல் ஐ வாஸ் ஆன் அண்ட் ஆஃப். அவங்க என்ன பண்ணுறாங்கன்னு எனக்கு புரியலைன்னாலும் பேசுகிற குரல் கேட்டது. ஆன் அண்ட் ஆஃப் ஐ வாஸ் ஏபிள் டு ஓப்பன் மை ஐஸ் அண்ட் see what is happening. I was able to see the monitor on the left side which I was ஒரு மாதிரி ஹேசியாக தெரிஞ்சுது. I think it took about 4 hours or so for the entire procedure to finish. காலம்பரை வந்து பார்த்தாங்க, எல்லாம் எவ்ரிதிங் வாஸ் ஓகே. இந்த இடத்துல இந்த கத்தீட்ரல் போட்ட இடம்லாம் எப்படி இருக்குன்னு எல்லாம் செக் பண்ணிவிட்டு அங்கே ஒரு பேண்டேஜை நான் போட்டுட்டு நீங்கள் இன்றைக்கி ஈவினிங்கே டிஸ்சார்ஜ் ஆகிடலாம்னு சொல்லிட்டு நான் டிஸ்சார்ஜ் பண்ணி விட்டுட்டாங்க. ஸோ இந்த ப்ரொசீஜர் முடிஞ்ச அன்றைக்கே ப்ரொசீஜர் முடிஞ்ச மறுநாளே வாஸ் ஏபிள் டு ஸ்டாண்ட் அப் அண்ட் வாக். I also happened to talk to a friend of mine who was done bypass surgery. அவர்கிட்ட பேசினேன். ஸோ அவர்கிட்ட பேசிக்கிட்டு இருந்தபோது அவர் சொன்னார், பைபாஸ் சர்ஜரி முடிஞ்சு நான் வந்து 10 நாள் ஆஸ்பத்திரியில் இருந்தேன். அப்புறம் ஒரு 2-3 மந்த்ஸுக்கு ரொம்ப ரெஸ்ட்ரிக்டட் ஆக்டிவிட்டீஸ் தான் கொடுத்துருந்தாங்க அப்படின்னு சொன்னார். As against that, I was able to walk on the next day itself and I was able to take care of my own routines. I am thankful to Dr. Gopal Murugan and his team for their excellent effort put on me for me to be back on my routines so quickly. I also take this opportunity to thank Dr. Sivakadaksham for putting me to the right person at the right time for the right treatment, because of which I am sitting now here and talking to all of you. Thank you so much.
Yes, nice visual. Great story. So take home message from what the patient said was, முருகனை நம்பியோர் கைவிடப்படார். அது கருப்பு சட்டைக்காரராக இருப்பினும் கோபால முருகனை தேடி வந்தால் குணமடைவர் என்பதுதான் டேக் ஹோம் மெசேஜ்.
இப்பதான் குகனா தெரியுது எனக்கு. I think the important message is it's a big team effort. We are very fortunate in Kauvery to have a good team. ஏன்னா இப்போ முந்தி மாதிரி ஒரு டாக்டர் வச்ச ஹாஸ்பிட்டலோ இதெல்லாம் it's no longer feasible. I think cardiology itself is such a large specialty. You need specialists within cardiology who can manage different things. I think Kauvery, fortunately, we have so many heart specialists who have their own expertise. Acute heart attacks, I think Dr. Sundar does a lot more heart attacks here. He's an expert in endovascular. So any complex shocks, we get help from Dr. Sundar. And as a result, at the end of the day, the patient gets the best outcome. Remember, highly complex CTO and the mari irunda, of course, my respected colleague Dr. Anbakarsi we refer, and they get a very good outcome, because at the end of the day, these are the experts that are very good in certain things. In between nadula varad mattumda I'm doing it. So, and moreover, it's not just the experts. I think it's important you have the right kitchen to be able to do the kind of cooking you want to do. So adukku Kauvery has one of the best facilities that we are all very fortunate. It's one of the very few hospitals in South India that has everything in one roof. So it's like a supermarket. You have all subspecialties of cardiology being able to be cared for, and all treatments can be done safely and securely in the best possible way in the world. So I think we are very fortunate in Kauvery to work in team effort, and a lot of support from management. I think I've always found Kauvery run by clinicians. I've never had a corporate feel because it's run by clinicians. Our owner, our promoters, everybody are practicing clinicians. They actually know what's happening at the ground level, so they can relate to it and they address our problems. So I'm very glad, and I think it helps us positively.
The panel is open for any question and answer from the participants. Open for discussion. So, like before the questions start coming in, few questions from my side to Dr. Andakarasi, Madam, and how many CTOs do you do on an average in a given month?
So I do 3 CTOs per week. So my volume per year is about anywhere from 90 to 100 CTOs. And again, it's a slow process. First arm chipper, we were about 5 years ago when we started, we were doing 4 a month, but now we are doing 3 to 4 a week. And I think one of the common questions which is always asked is what success rate you quote for the patient, what complication rates you quote for the patient. In experience hands, in my personal results, 85 to 95%, 5 to 7% complication rate. Bypass surgery in the 10% complication rate of strokes, everything. CTO PCI is about 5 to 7%. Now, a regular angioplasty is less than 1%. So it's definitely more complex than regular angioplasty, but it is not as extensive as bypass surgery. It's somewhere in the middle. And patients most of the time go to a regular floor bed and go home the next day itself. And after a week, cardiac rehab, they are able to participate without any problems.
And we have like a selection criteria there, like you select the patients whom do you want to
அந்த மாதிரிலாம் cherry pick பண்ணவே கூடாது. So there are two things, like anatomy symptoms இருக்கா, if the patient கஷ்டப்படுறாங்கன்னா we have to find a way. Symptoms and viability, அது வந்துட்டு you want to fuel a field which can grow, or that's why if there's only scar tissue, there's no point revascularizing scar tissue. So viable myocardium, symptoms which are refractory to therapy, CTO PCI, irrespective of anatomy, I go ahead and do it. I give it a shot, at least. Let me put it that way.
Sir Gopal Murugan, sir, you want to add something?
No, certainly. One of the important points that I'd like to re-stress, which Dr. Anpakarsi mentioned, is the cost. People think there is a notion that very expensive because multiple kits are used. But I have seen Dr. Anbakarsi operating, and she probably uses far less kit than what I would use for a normal angioplasty. I think it goes to show when it's done by an expert, I'll be doing a lot of catheters, but when a specialist cooks, they go for the right catheters. In fact, it works out pretty much the same cost, and I was very pleasantly surprised how she's able to manage, and I think it's largely down to expertise, and I think which is why it's very important we have teams for each area of specialist angioplasties who can deliver the best because they do very high volumes. So I think the cost thing is very important. It's very cost effective, and it's no longer an expensive procedure as it used to be perceived.
Thank you, sir. And the first question has come in, but before I go into the question, I'd like to put a question forward to Dr. Sundar. ECG Sir, what do you feel that in the pandemic time, do you feel that the number of cardiac cases have come down? It is a paradox, or people are not, due to fear, they are not coming to the hospital, or is there definitely the cases have come down, the incidence of MI? What do you think, sir?
First of all, good evening, everybody. Dr. Anpakarsi, Dr. Gohan, Dr. Gopal Murugan. Thanks for the opportunity. So first of all, during the initial days of pandemic, we thought it was coming down. Actually, the cases were little down because of the fear in the people's mind that all the COVID patients are in the hospital. They don't want to get exposed. ஈவன் நீங்க நிறைய ஜோக்ஸ்லாம் கூட படிச்சிருந்திருப்பீங்க, லைக் ஹாஸ்பிட்டல் போனோன்னா நல்ல வேலை அவர் ஹார்ட் அட்டாக்னு சொல்லிட்டாரு, கோவிட்னு இல்லை அப்படின்னு. ஸோ previously before COVID, it was the heart attack which was the most killer disease. Everybody had so much the precautions. Even ஒரு சுண்டூரல் வலிச்சா கூட ஹாஸ்பிட்டல் ஓடியாந்துருவாங்க. ஸோ இப்போ வந்து COVID has taken over that fear factor from the heart disease to the COVID. ஸோ அதனால நிறைய பேஷண்ட்ஸ் வந்து they didn't come to the hospital அப்படிதான் சொல்லுவேன். பிகாஸ் ஆஃப்டர் மார்ச், ஏப்ரல் we were we were surprised to see lot of late presentation. Lot of presentation in the sense, சார் போன மாசம் எனக்கு லேசா வலி இருந்த மாதிரி இருந்தது, பட் கொஞ்சம் தண்ணி எல்லாம் குடிச்சோன்னா கொஞ்சம் சரியான மாதிரி இருந்துச்சு, பட் இப்ப மூச்சு வாங்குது அப்படின்னு சொல்லி. So lot of LV dysfunction, lot of late presentation came out. And also the one of the things on the Kaveri level, we never stopped the emergency care at all. So we were surprised to see lot of patients who came from other hospitals where they didn't take up the patients. அதனால கூட நிறைய ஹாஸ்பிட்டல்ஸ்ல இருந்து காவேரிக்கு நிறைய ரெஃபர் ஆகி வந்தது. ஸோ இன்ஃபேக்ட் நீங்க த நம்பர் ஆஃப் கேத்லாப் ப்ரொசீஜர்ஸ் இந்த கோவிட் டைம்ஸ்ல கூட பார்த்தோம்னா காவேரியை பொறுத்த வரைக்கும் ரொம்ப ஒன்றும் மேபி ஹார்ட்லி கேம் டவுன் ஒன்லி 10%. அண்ட் த நம்பர் ஆஃப் அக்யூட் கேசஸ் சர்ப்ரைசிங்லி வெண்ட் அப். So not STEMI, even the end STEMI and delayed presentation அதெல்லாம் இருந்தது, பட் அந்த மாதிரி acute presentations எல்லாமே it went up. And elective procedures வந்து first March and April we didn't touch because of the stable angina. இதெல்லாம் வந்து we were maintaining with the medications only. And after that இப்போ the protocols எல்லாமே we have found we have formulated, and we have a very clear guidelines also. So இப்போ எல்லாம் elective patients எல்லாத்தையுமே we have started doing. So this is the thing. And definitely the heart disease incidence கம்மி ஆகல. அது வந்து because once the patient reaches the hospital only we will have the data. If the heart disease patient வீட்டிலே உட்காந்துட்டா டேட்டா கிடைக்காது நம்மளுக்கு. So that is the misnomer அப்படின்னு தான் சொல்ல முடியுமே தவிர ஹார்ட் டிசீஸ் இம்பாக்ட் இன்னும் கொஞ்சம் அதிகமாக தான் ஆயிருக்குன்ற மாதிரி தான் சொல்ல முடியும்.
Yeah, so thank you, sir. Thank you. And there has been the question from, I think Dr. Gopal Murugan has already answered it. But anyway, for discussion, a lady 40% block with distal bridging with angina pain, how to manage? Sir has suggested an FFR. What is the difference between FFR and an intravascular ultrasound? Sir, is this the same or is there a difference?
There is a difference. Intravascular ultrasound or OCT, it gives anatomical information. You can see inside the vessel, you can calculate the mean luminal area, and if the mean luminal area is above a certain number, you don't need to perform angioplasty. FFR it gives functional information. It measures the pressure below the narrowing and above the narrowing, and if the pressure below the narrowing is less than the pressure above the narrowing, it means the narrowing is significant and they need to treat it. If the pressure below and above are the same, whatever narrowing we see on angiography, we don't need to treat it. So it gives us functional information, and it's one of the best methods to prove in intermediate disease whether treatment pananuma illiyandra mudivu it makes it very scientific, and that's the best way currently available.
Thank you. What do you see the future of interventional cardiology? Like, this is an open question to the panelists. Since COVID, like, it's an RNA virus. Again, RNA virus are prone to mutations. So least of a form can come, but it is going to be there. Even if there is going to be a vaccination, it's not like we'll be able to err person. So we have to like protect ourselves and the patient from here on. Like, are these precautions going to be there? Is the number of CT, HRCT of the chest or the RT-PCR is going to come down? Is there going to be any cheaper alternatives, or this is going to be the way of life from here
on? Well, I think it's very difficult because namalike theriyadu enna aaga podunu. A lot of answers are going to be speculations dane. I think to answer the first point, in terms of safety for us and staff, there is always going to be a concern. We're always going to be high risk because we have to deal with patients who could be COVID positive. And COVID positive therinju, if they have an emergency, we have to attend to it. Vera vali illaya. Ranuvathila sendittu por vandona pomaatenu solla mudiyadla. Vera vali illa. You have signed up to it, we have to go for it, and we have to take that risk. Adula vera valiye kediyadu. Moving forward, I think we have to learn to live with it. That seems to be the case, because as of now we have no signal as to when COVID will go away. அதாவது கோவிடுக்கு அப்புறம் வைத்தியம் பண்ணிக்கலாம். There's no such thing as கோவிடுக்கு அப்புறம். That's not going to happen because we don't know when it's going to go, and nobody has any signal of exactly when this is likely to happen. So therefore, as of now, we have to learn to live with it, take precautions, and above all, bear in mind, I think at least from a heart perspective, that's what we know, is that heart disease is likely to kill somebody 17 times more so than from COVID. That's a very important information people need to understand. So நிறைய patients already I have seen in the last 4 months, they've been shying away from treatment, thinking ஏதாவது ஹாஸ்பிட்டல் போனா கோவிட் வந்துருமோ. Of course, it's right that they are at risk of getting COVID, but then if they do indeed have a significant heart disease, that is more likely to cause harm to them than COVID itself. So adukku perhaps video consultation பண்ணலாம் உங்க family physicians who they know very well, because family physicians would have been seeing those patients for years. The best thing is to check with them, and if they feel they are safe, then they can wait. Otherwise, it's better to get help and see a specialist with guidance of their regular physicians. And moving forward with vaccine, vanda nalladhu, ellarum we're all waiting. வேலை பார்க்குமா இல்லையான்னு யாருக்குமே தெரியாது இல்லையா, ஏன்னா it hasn't been there for years. So வந்தா தானே தெரியும். So I think we don't know what the future is going to be. This uncertainty is going to continue. That doesn't mean that we stop what we have been doing. We have to just continue. We have to live with it safely and securely, and always making sure that patients are safe at all points.
Since we have the primary PCI expert, the CTO expert, and complex multivessel angioplasty expert in the panel, little bit of the question, a controversial question, or maybe non-controversial also. So is the CABG for triple vessel disease with or without LMCA, or the role of a cardiothoracic surgeon for an ischemic heart disease, is it going to be obsolete in the near future? What is your takes on it? And if not, where do we draw the line? Like this is a patient for definitely CABG and not CTO or multivessel. Where do we draw the line? It's open to the panel.
So that's a tough question. You can't say CT surgery will ever be obsolete. அவங்களுக்கும் ஒரு ரோல் இருக்கு. நம்ம ரோல் எப்படி நமக்கு இருக்கோ, there is a role for thing. Are they doing less? Stents வந்தப்புறமே surgeons or volumes have gone down. Okay, so முன்னாடி stents வந்தோன்னா, they gave in the beginning of PCI, surgeons were doing so many coronary artery bypass surgery, and literally cardiologists இந்தாங்க எங்களுக்கு டைம் இல்ல, நாங்க ரொம்ப சர்ஜரி பண்ணிட்டு இருக்கோம், போங்க போய் PCI பண்ணுங்கன்னு சொல்லி நமக்கு ஆல்மோஸ்ட் பிச்சை மாதிரி போட்டாங்க. But of course we cardiologists took it over, and the number of coronary artery bypass surgery has come down. And the same thing with valves வரும்போது ஸ்மார்ட் ஆயிட்டாங்க. ஸ்ட்ரக்சரல் பண்ணும்போது சர்ஜனும் இருக்கணும், சர்ஜன் இல்லாம ஹார்ட் டீம் அப்ரோச் ஆச்சா பூச்சான்ட்டு they found a way to stay relevant, which is survival. I completely understand, and Gopal Murugan can talk about the role of a surgeon in structural procedures also. So I don't think they'll ever be obsolete. There will be situations where surgeons will also have a role. And there will be procedures, I mean, when you have a quadrification left main, where, you can't save all the blood vessels, or, there will be special situations where, there's all the way distal vessel disease, you can't put a stent there. And maybe you have a skillful surgeon who can attach a lima to the distal LAD. Under many special situations, I think you want the surgeon to be around and have the expertise to do that.
It's a tough question to answer, but நீங்க சொன்ன மாதிரி slowly the part of the cardiothoracic surgeon, the space of the cardiothoracic surgeon is slowly eroded by interventional cardiology, definitely in all the sense. Like coronary artery bypass matrum kadayadu, then as TAVR, and TAVR also we can include this because that day even in the last month we did 2 TAVRs with Dr. Gopal Murugan, and the surgery which takes 3 to 4 hours, and the recovery which takes at least 21 days for the patient, For the TAVR, you remember that patient, Dr. ABG might be remembering, that patient, he came to the OP in a wheelchair, and he went out by walking in 2 days. So this happens. See, this is the necessity of time. ஸோ அந்த காலத்துல நம்ம சைக்கிள் ரிக்ஷால போனது மாதிரி இப்ப பென்ஸ் அந்த மாதிரி போறது, அந்த சொஃபஸ்டிகேஷன், this is the what we can say, the importance of medicine and the growth of the medicine. So everybody has to accept that, and definitely there is a role for the cardiothoracic surgeon, and definitely we are not undermining their role, because a lot of the complex cases, even in complications, they used to bail out us, and we have a very good surgical friends also, and their role also is important, because we can't say 100% of the cases will be done by this thing, but definitely the portion of the role of the intervention cardiologist has increased, and the space of the cardiothoracic surgeon has decreased, but definitely it's they are very much needed.
I think in answer to your question, Dr. Guganathan, I think there are a significant number of patients who will benefit from arterial revascularization. Nama in the bypass data lam pathina, majority of the bypasses that lasts long and does really good are total arterial revascularizations. அந்த மாதிரி நிறைய surgeons are doing it. Perhaps that will be the best option for young people. Maybe somebody in their middle age, if they can have total arterial revascularization. And I know some fantastic surgeons in Chennai who do nice, minimally invasive, just 3-4 incisions, and they walk home in less than a week's time. And அந்த role கண்டிப்பா இருக்க போகுது. I think vascular surgery, CABG continues to be there, and நிறைய இது we do all this left main and complex angioplasty we do because friend bailout we are also doing it. So without them there is no complex angioplasty. We have to accept it. So which is why I'm a great fan of a true heart team approach in spirit. So vaai vaarthiya sollama really manasukulle or a surgeon has to be part of the team. Adilana, how can you deliver a holistic cardiac care? So thankfully we have fantastic surgical teams here who are always supportive. They just support whatever is best for the patients. When we do TAVRs, when we do endovascular, they're always by the side to bail out. So surgeons' role vandu enikume kammiya poradilla. They're part of the team, and we have learned more from the surgeons. Avanga ithana varshama pannadilana kattukitadana we have started to find out what are the better ways, minimally invasive ways to learn. So we shouldn't forget that. So they're certainly going to be an important part of every treatment, and without surgical input and a heart team approach, there isn't quality care for the patients.
I think it's going to be a hybrid approach. There are more and more hybrid procedures which is going to happen. Gopal Murugan Saramari or a mini cabbage, Lima to LAD put circumflex, RCA class stents, and the madri, because the stents are definitely better than vein grafts. If you're not able to give arterial revascularization, Lima to LAD panita, RCA and circumflex stent, and the madri hybrid methods. The role of the surgeon is evolving. In some centers, including my centers, the CT surgeon comes to the cath lab so that he learns how to move wires and stuff like that. So everybody is evolving right now.
Yeah, thank you, madam. I think, yeah, the hybrid is the right word. Like in Kauvery hybrid cath lab, I think sir and his team are the first to do the multivessel PCI, TAVR to the trans iotocaval approach. Did I include everything or did I leave out anything? I think sir was one of the first persons to do that procedure. I think in Southeast Asia or in the world. I'm not sure about that. So I think these are the typical classical examples of hybrid procedure wherein the entire team is important. And the major take-home point is we perform as a team to ensure that the patient gets the best treatment and the least invasive approach so that they can go home at the earliest, either it be pre-COVID or during COVID or post-COVID. This is going to be the scenario. So I don't see any further questions. Shall we close the session and the discussion, sir? Or is there the panel wants to discuss? So thank you. I sincerely thank the IMA Kauvery and Kauvery Hospital, Dr. Gopal Murugan and Dr. Sundar for giving me this opportunity to present. Thanks for Dr. Ranbukar Maran for joining us all the way from South Carolina, and we are waiting to meet you next time when you visit Chennai. Thank you. Thank you.
Thank you.
Thank you. Thank you very much.